I do prefer to go by Dr. Chandrasekharan, and I'm a medical oncologist at the University of Iowa now with a focus on neuroendocrine tumors since 2017. I was fortunate to work with Dr. Rizio and learn from him, and I continue to learn from the excellent team, Dr. Howe, Dr. Dillon, and everybody else here that you've all heard from. So I'm going to be speaking about medical oncology approach. Again, a lot of times as a patient with a diagnosis of neuroendocrine tumor, the first person you see in the community is often an oncologist. But I cannot emphasize enough that it is definitely and never ever will be a one specialty show in this cancer. We need the input from all the other specialties and multiple other people that you see and do not see behind the scenes that actually can formulate a good treatment plan for you. So just a little bit of history again. This is the original description of a carcinoid tumor in 1867, the original paper that's here. Sorry, I have to read here and point there. That's a little hard to coordinate. So this is the original paper where the description of carcinoid tumor was, where then 2 patients were described in an autopsy in 1888, and then finally the term was coined by 1907, where it looked like a cancer but not quite like a cancer because the tumor was a little bit more slow growing. And then went on with the hormones being identified, the cell that was secreting the hormone, and then identifying that the serotonin is one of the big players of your syndrome. Now, the term carcinoid kind of started with that in 1930s, where people were trying to figure out what this all means. The term carcinoid stuck for a long time in the 1980s when we knew a little bit more, and we also started having therapeutic advances. In addition to surgery, at that point in time, it was octreotide or a type of chemotherapy or this chemotherapy or interferons, which were probably drugs that we don't use often now, but back in the 1980s, it was used for pretty much every cancer too, so playing with the immune system. But now we have moved on a couple of decades later and continue to advance with more therapeutics. I think the advances have been much more rapid in the past few years than it has been in all the prior decades for good reasons. So one thing we have to remember is every patient with neuroendocrine tumor needs an individual treatment plan. And that's because there is no one size that fits all. So there is really no standard protocol, which is a little bit difficult even for an oncologist because I take care of patients with other cancers, and typically there's an algorithm of some kind. Okay, first time you have a pancreas cancer, this is your first round of treatment. If this doesn't work, we're going to go on to the second round, so on and so forth. Now, unlike that, neuroendocrine tumors, they have mismatch of so many other disciplines that take care of the patients with this cancer. And there is no particular algorithm or particular thing that can be applied for every person. So that's what makes it unique and challenging and also sometimes difficult as a patient because, when I sometimes tell a patient, you can do this, you can do that, you can do that, like, do you really not know what you're telling me, or is this how it is? Because truly there are multiple ways to approach the tumor. So there is, like I said, also difficulty because we don't have a great marker always to say the sequence of therapy. Now, there are obviously some things that help us choose treatment. Somebody who has a tumor which has receptors for these octreotide receptors you've been hearing about, obviously PRRT could be a choice for those patients. So there are things that help guide treatments, but again, there is no good treatment plan or treatment algorithm of what goes first and what goes next. So this is a shared decision-making process based on multiple things. Patient symptoms, the site, the tumor, the grade, the stage, so many other things that go into it. And again, as I said, just listing a few of the specialties that work or are interested in this tumor type: surgical oncology, endocrinology, nuclear medicine doctors, medical oncology like myself, gastroenterologists who help us make diagnosis sometimes or manage some of the localized tumors like in the rectum, interventional radiologists like Dr. White who spoke earlier, radiology who reads every one of your scans, pathologists who are key to just kind of help guide management. So this is just probably not covering the other disciplines like a dietitian, the importance of a cardiothoracic surgeon who helps with the carcinoid heart disease, so many other specialties, but this is just a small list. So it's hard to provide all this care sometimes in a small community center, and that's why the emphasis of seeking out expertise from a larger center that probably could have all these places in one roof. I like to call this MindNet framework because anytime and every time I see a patient, this is kind of where I start. I try to put that patient's situation in this framework so we can make a good treatment plan. Now, this is a framework that's not just a diagnosis. I kind of go back to this every time we have to make a decision about any treatment change or anything that's changed. So like I said, this is again not all inclusive, but these are the big factors I would say that as a medical oncologist, this is how I want to visualize this cancer and this patient situation. So site of origin, this is a graph you've probably seen in every conference where there's clear increase in incidence from 1 in 100,000 in the 1970s of all type of neuroendocrine tumors to 6.98, which is like 7 in 100,000 patients in the population. So there's clearly an increase in this time period. And if you look again at the origin of tumor, so site of origin, like I said, the largest increase has actually been in lung neuroendocrine tumors and rectal neuroendocrine tumors in this black. There's also been a steady increase in the small intestine origin tumors as well as the others, to a smaller extent the other origin. Now, is this a true increase? Are we really seeing more neuroendocrine tumor patients of lung origin, or are we doing more CT scans for other reasons? And that's why we're picking up these tumors early and small. Are we doing more colonoscopy? So we're picking up more of those rectal neuroendocrine that are like 1 or 2 centimeters that, that could be part of the reason. So it's really hard to conclude when you see these two tumors origin increase, is it actually because there's an increase in incidence or the other confounding factors? But regardless, the site of origin matters for treatment selection. So the current treatment paradigm for small bowel neuroendocrine, the toolbox as I refer to sometimes, is for small bowel neuroendocrine surgery, liver-directed therapies, octreotide analogs, which could include octreotide or lanreotide, everolimus, which is also referred as Afinitor. I did put interferons, though personally I've never actually given anybody interferons myself, PRRT. And I put the question mark cabozantinib. It's not yet FDA approved, but I'm putting that out there because this is a new drug where there's a phase 3 clinical trial. A phase 3 clinical trial refers to a very large trial, very robustly done with a lot of patients, where you're testing out a drug, either a drug against a placebo. So a trial like that has been conducted and completed and reported with this drug called cabozantinib. And of course, I always include as a medical oncologist a clinical trial as an option for the patient. When we look at pancreatic neuroendocrine tumors, slightly different. You will see some overlap, obviously, with many of the treatments that's not site-specific, so surgery, liver-directed treatments, octreotide, everolimus. But one extra thing that you see here is sunitinib, which is basically what we refer to as tyrosine kinase inhibitor. So some people may hear that term. Sunitinib or Sutent is a drug pill that actually has a different mechanism of blocking the tumor growth, and that's has been studied only in pancreatic neuroendocrine tumors. We also see chemotherapy listed here, and I didn't quite list that in small bowel neuroendocrine tumor. Pancreatic neuroendocrine tumors sense of origin tend to be more sensitive to the effect of chemotherapy. Though in the old studies that we have, chemotherapy was also used in small bowel neuroendocrine tumors. We now know that pancreatic neuroendocrine tumors definitely have more sensitivity to these chemotherapeutic agents. There's also some that are historic context. Some people may have received drugs called streptozotocin and other things, but in the modern context, we usually refer to as CAPTEM or capecitabine temozolomide. Again, cabozantinib, which is not yet FDA approved, but a large phase 3 trial, I put that up there, that also included patients with pancreatic neuroendocrine and clinical trials. So what's not covered is the other sites of origin, like the lung neuroendocrine tumors. I know they're often not included in many trials. They're slightly different, but some of the options that we discussed do overlap, and they do exist for also lung neuroendocrine in the same way with rectal. So knowing the site of origin is very important if we can. We'll talk a little bit about how to know the site of origin. Sometimes it's very obvious. All the pictures Dr. Howe showed with this lymph node in the belly cavity often is a telltale sign of a tumor that is coming from a small bowel. Sometimes a pancreas origin neuroendocrine tumor is very obvious on a CT scan. The cancer lies obviously in the pancreas. Now sometimes we have challenging situations where we really don't see anything and we just see liver metastasis. In some situations like that, getting a gallium PET CT helps, because a PET CT has a little bit more sensitivity to kind of find out or hone in on a primary tumor that may be small. We also take an approach through pathology, meaning looking at the tissue. I'll go over that in the later slide, but Iowa uses a panel of protein testing on this biopsy report that helps us also weigh in this is likely a tumor starting in the lung or likely a tumor starting in the small bowel or pancreas. But knowing the site of origin when you can, it is helpful to decide your treatment options and tumors, as well as the symptoms, of course, based on that. Now, stage of cancer is different from a grade of the cancer. Staging is used as a way to tell where the tumor started and where it has spread. Instead of stage 1, 2, and 3, 4, which is often the concept in many other cancers, I think it's simpler to think about in neuroendocrine tumors locally advanced or metastatic. So locally advanced refers to if a cancer is just confined to the organ where it started. So for example, if a small bowel neuroendocrine tumor is present and just the lymph nodes in the belly cavity, like Dr. Howe's prior pictures, that's a locally advanced without any spread to another organ. Or if it's just in the pancreas with maybe some lymph nodes around the pancreas, what we refer to a regional lymph node, which is like the first area the cancer cells drain to, that's still locally advanced. Metastatic disease refers to anything that's spread to another organ. So for example, the most common site, as we all know, is liver, but you could also have spread in a non-regional lymph node. So for example, if somebody has a cancer in the pancreas or small bowel, occasionally we see patients who have a PET scan that just lights up in like a lymph node in the neck region or supraclavicular region, as we call it, and that is still a distant spread because it's not that first portal of the cancer cell draining. It can also be present, another common area, especially for belly cancer, is peritoneum. Peritoneum is that gross yellow stuff Dr. Howe showed, like the fatty tissue within the belly cavity where these tumors can be studied. Bones are also known sites. Now, I think in the older literature, when we only had octria scans, which is like the fuzzy images, sometimes the sensitivity of those scans were not very, very good, and people probably had cancer in the bone but didn't really know about them. With gallium PET scans and copper PET scan, where the sensitivity of the scan is so high that 5 millimeter tumors, so that's very small, can be picked up, we are definitely seeing those patients with like, bulk of the disease is in the liver, but here's 1 or 2 spots in the bone. I mean, technically it's in the bone. So it can be a variable presentation. It partly could be because we have better scans and better eyes, better glasses to look. It's hard to know what that means in a patient care right away. So there are also other sites of disease like ovarian origin and ovarian spread, like discussed. So for locally advanced cancer, the paradigm is always to go with the curative intent, and that's the only situation where we can claim cure, in my opinion, where you can go, take it out, take everything out, and hope for the cancer never to come back. So in a small bowel neuroendocrine tumor, this would involve a surgery by Dr. Howe or his colleagues in their institution where they take out all the lymph nodes as well as the areas of the small bowel tumor. In a pancreatic neuroendocrine, the surgeries are much more extensive, as already described. And as you can see, the size of the tumor in pancreas may dictate some of the treatment options or discussion points. So stage of cancer is important because if I'm seeing as a medical oncologist a patient with a tumor that's just confined to the pancreas, yes, I can talk to them about octreotide therapy and PRRT, but if they are resectable, if this can be removed, I should be sending them to the surgeon first. And I always say as a medical oncologist, I don't get to decide surgery. The surgeon and the patient gets to decide on surgery, right? So always make sure that the opinion is at least obtained while you make these decisions. A medical oncologist can still not be a good person who can assess surgical things. So I always say, Dr. Howe, you have to take a look before I can say anything. So a little bit more about the grade and differentiation, as we don't have a pathologist speaking. This is probably one of the most important factors that dictates the behavior of the tumor. Now it is not the only factor, but definitely one of the most factors. And grade is different from stage because often patients come in confused. Oh, I'm grade 3, what stage 1, or like what is the deal? So stage, as I said, is different, grade is different. So grade is referring to how the tumor is behaving, and often we get this information from a biopsy or a surgery or like a specimen, like a tumor specimen. So in oncology, the tissue is the issue, right? Tumor is a rumor until tissue is there. So we always like our tissue. So the classification of neuroendocrine tumors has also changed over the years. Back in 2010, I mean, I'm not going back even prior to that, but in 2010, for example, we would call gastroenteropancreatic, meaning those that originated in the gut, based on the proliferation rate, grade 1, 2, and 3, and then basically low grade, intermediate grade, high grade, and all the high grade tumors were either classified as small cell or large cell. I'll show you some pictures of what I'm referring to. And then lung and thymus origin were classified slightly differently. They were called typical carcinoids and other things over the years, and some of that classification is stuck. So one important change, we are trying to move away from the word carcinoid because, like I said, the historic context is great, but sometimes that raises the question of, is it a benign tumor? Is it a malignant tumor? Is it spreading? Can it spread? And then along the way, we also realized that we clumped together all these patients in this high grade. There was a set of patients whose tumors were not as slow growing as these, but not as fast growing as what we call a small cell or large cell. So this grade 3 category came about. And then there were patients whose tumors had some components of a traditional cancer in the colon or pancreas, what we call an adenocarcinoma, and then they had a little smattering of neuroendocrine type of cells, so like these mixed tumors. So all this is important because the key thing, first thing a patient actually looks at is a biopsy report for confirmation of a cancer. And these elements, it's not just having neuroendocrine tumor, it's these elements that really help make a treatment plan. So again, I just put down the classification, but to actually look at the pictures, the words that should be helpful to be familiar with is this word called Ki-67 and mitosis and grade. So basically we're referring to different ways to measure how the tumor is growing or dividing or proliferating. So for example here, I have what a grade 1 tumor and grade 2 tumor looks like. This is how things look for the pathologist under the microscope, some tissue that has these glands like formulated here. And then this is what we call a Ki-67 stain. So you have to see these brown colored dots, which is the stain that we are looking at. So when you see these dots, that's what you're counting as Ki-67, or Ki-67 as some people call it. And you're trying to look for a spot under the microscope that's looking actively growing, and then put this dice in these areas to count and express as a percentage. So roughly if there are 100 cells and you barely see 1 or 2 cells dividing, that's like a grade 1 tumor. When you see about maybe 10 cells dividing here, what we call a Ki-67 of 10%, that's slightly faster growing. On this end is what we now refer to as a carcinoma, neuroendocrine carcinoma. So if you look at this, there's a lot of cells, a lot of chaos, and there's a lot of these tiny cells, small cells. And this is a Ki-67 stain. You know, here on this end you see barely any of the brown. Here you see a lot of brown. So that's basically a Ki-67 of 90% or something. So that's a very, very rapidly growing dividing tumor. And then this is another example of still a very rapidly growing tumor because you see a very high brown stain on the Ki-67, but the cells themselves look a little larger, so we refer to as large cell carcinoma, neuroendocrine carcinoma. Now there's this category, like I said, where the patients have somewhat of a very organized looking tumor, so they are not ugly looking like this, but they are somewhat organized. But when we did this dye called the Ki-67, they're not like less than 20%, so that's the classification for grade 2. So that means like say maybe 40 cells are dividing in this little view. So that's the well-differentiated grade 3 neuroendocrine tumor. So we were initially putting everybody into 1 and 2 or low and intermediate and all of this into one lump, and we realized these patients, this ugly tumors or fast-growing tumors did worse than these patients, and these patients did somewhat worse than them but better than this and a very variable course. So that's very important. And then I wanted to also point out, because in a pathology report sometimes people hear, do I actually have a neuroendocrine tumor, a neuroendocrine carcinoma, or an adenocarcinoma? I think our pathologist, Dr. Belize, says, I think he revises at least 10 to 15% of pathology reports that come from the community to our institution for a second review. So that tells us pathology is very key. So sometimes, for example, on this end is actually a breast cancer. This is breast cancer with the dye called synaptophysin. So synaptophysin is a dye that's often present in neuroendocrine tumor cells, and you can see this is very bright and positive. So just because it is expressing synaptophysin, some pathologists without a lot of familiarity with this tumor may call it a neuroendocrine tumor, and it is not. It is actually expressing another stain called GATA3, which is present in breast cancers, and it doesn't look like a neuroendocrine tumor. So this is actually a breast adenocarcinoma, which is like a breast cancer with neuroendocrine elements. Now you treat those patients as breast cancer, and they may do slightly worse than the regular breast cancer, but and this is hormone positive, meaning this is the estrogen receptor. So this is breast cancer with a neuroendocrine, I guess, flavor to it. On this end is this collision tumor that I would refer to, which is often found in colon. So here's a polyp and cancer in the polyp. On this side you see the actual cancer elements zoomed in, which looks different from this side, which is the neuroendocrine elements. So within this area, you had one place looking like this and one place looking like that. And then this is a stain called CDX2, which is often present in a colon cancer. And you see this area stains for that, but this particular area stains for synaptophysin, which is like a neuroendocrine. So essentially this tumor here had two components, adenocarcinoma, which is the traditional or the regular colon cancer, and neuroendocrine cancer, neuroendocrine carcinoma. And we use a stain called RB, which is like a certain protein, and usually that's lost in the neuroendocrine part, so RB loss. So this just tells you the complexity. So when we say we don't like to see you without a pathology report, this is exactly the reason why. You know, as a NET center, if you go to any NET center, the first thing they want is your tissue to be read by an expert pathologist, because I cannot tell you the number of times I've had a patient that was called a grade 3 neuroendocrine tumor, and it ended up being one of these or something else. And again, that's important to know before we make a treatment plan, because I could be telling them something totally wrong if I did not know what is actually the tumor. So with that, the classification has changed to include these changes. Like I said, patients who have this high proliferation but somewhat well-differentiated or organized tumors, and then the poorly differentiated, which usually are these aggressive, fast-growing tumors, and very high proliferation. And then we change those collision tumors, as we call them, those who have neuroendocrine and non-neuroendocrine, to a slightly different. I can brag and say that unfortunately for patients who have these minors in grade 3 or high grade, medical oncologist primarily becomes the treating party, because these usually do not have receptors or don't have PRRT or the other traditional options. Now in some patients we still do surgery, in very selected cases, selected patients. So a lot of times in these situations it's drug therapeutics or systemic therapy, as we refer to it. Systemic just means that goes all over the body. So those kind of options are the best options for these patients. So again, for the site of origin, this is Iowa's pathology scheme that we use. If the patient has this particular protein called CDX2, so people come in as an unknown neuroendocrine tumor, but having a CDX2 tells us this is likely a mid-gut origin. One of these markers, islet-1 or PAC6, tells us it could be in the pancreas. And then there are also patients who have lung origin, and we use a particular stain called OTP1, which is present in these lung neuroendocrine tumors, and rectal, for example, SATB2. So this is kind of our algorithm for trying to differentiate the site of origin. Again, these are things that, again, a high volume neuroendocrine center likely will be able to offer as a routine. We do this on all patients. And then also, sometimes for the G3 or the grade 3 patients who have the higher grade, we try to do RB stain, like I said, a particular protein that tells us more about the behavior. Now there's a little bit of controversy still in using this in practice, but we are doing it in most of our patients with the higher grade tumors. So site of origin, like I said, is important, grade is important, and sites of metastasis is important, meaning where is the tumor located? Is it only in the liver? Is it outside the liver? If it's outside the liver, how much is it outside the liver, and where are the locations? Because if somebody only has liver dominant or liver only metastasis, certainly I don't think any oncologist, even though we have all these drugs, want patients to have diarrhea, nausea, vomiting, all the side effects you hear about these drugs. So thinking about surgical options or embolization options may be perfectly like a very good first approach for those patients if this is liver dominant. But if you have multiple sites outside the liver, then you want to pause and see the value of those liver-directed treatments. It's not for everybody, but in some patients. Probably one of the hardest location situation is this peritoneal metastasis, which is like the belly cavity. Cytoreduction, meaning like a surgical debulking that Dr. Howe does, is still an option. PRRT may still be an option. Drug therapy is always an option. But this is somewhat of a hard area for any of the drugs, any of the therapeutics or drugs to get to. So it also helps us to know the surveillance and imaging plan. If someone has primarily disease in the liver, we probably, in order to reduce the amount of imaging and exposure you get, just kind of go with more liver-focused imaging and occasionally get other types of imaging. But if someone has, in a gallium PET CT, for example, significant amount of burden in the bone, even though they're asymptomatic, at some point in time, I try to at least get a PET scan or something else that tells us about these non-liver areas or areas that we cannot see very well on a conventional CT scan. It may also help us to be better prepared for what to anticipate. If there's a huge lymph node that's growing slowly next to a bile duct, maybe it'll tell us, well, maybe we should watch for pain or discomfort or jaundice or something. So many reasons why we need to know the distribution of metastasis. So for example, in one clinic day, I could see 3 different situations, and all 3 of them need a different approach. This is a patient on a PET scan with multiple liver and extensive bone metastasis, was actually symptomatic with pain. Or I could have a patient who's also symptomatic with carcinoid syndrome diarrhea, but just one big liver lesion. Or I could have another situation where it is also a neuroendocrine tumor, small bowel origin, but like peppered with liver tumors in this liver. So this is just one clinic day and 3 different approaches, 3 different patients, and I'm not even getting into grade 1, 2, or 3 of what the situation is. So it's important to know this before formulating any plan every time. So the same thing, next thing I also like to know is octreotide receptors or not up front. It is definitely recommended that you get some kind of a functional imaging, especially a diagnosis. Functional imaging refers to not just a CT, but like back in the day, octreotide scans, which I don't think anybody's doing octreotide scans, thankfully, these days now. It should either be a gallium PET of some kind or copper PET. Now, this is at diagnosis. Now, how often do we repeat them? Do we get them every year? Do we get them every 2 years? Do we get them when somebody has pain? Those things are not very clear. There's no good guidelines. I think it's more of an art and a practice that dictates that repeat imaging. When PETs came about, a lot of people were getting too many PETs, especially with local oncology, and they would always report sometimes the PET has increased in uptake or increased in receptors. They forgot to get CTs and MRIs. You know, PET doesn't replace those imaging studies. So it's in conjunction and it has a role, but it does not replace. So that's just important as a patient to know as well. So having receptors or not is helpful, again, to formulate treatment plans. So this is basically what we are looking at is a receptor called somatostatin or octreotide. If this is the cancer cell, imagine this is the receptor. Now, this whole PRRT paradigm for treatment hinges on this receptor being on the cell surface so that this is the PRRT molecule or the lutetium, which has got the radioactivity. So it has to be delivered for the cancer cell, get internalized to cause the DNA damage to the cancer cell, but it needs this particular receptor. Otherwise, the PRRT is not going to work. So this is an example of a patient who has a CT scan here with a large liver lesion that you can see. Probably what's harder to see is another liver lesion smaller down here. And the same patient has a gallium PET scan where you see this is the spleen, that's not tumor, the bladder, but in this liver, this big area of tumor has absolutely no uptake. There is a small tumor right here, which is gallium PET positive. So now again, in this patient, PRRT may not be a very good choice because there's no receptor for this big tumor that's actually the one that's giving him trouble. So receptor status is very important. Then the question is actually, who do we treat? Symptoms from the tumor bulk or the location, or it can be symptoms from the hormone secretion. And here I would like to emphasize about the role of CT or MRI and the role of the protocol of CT or MRI. This is the same patient who got a scan in the community, and this is the same patient that literally the next week got a CT at the university with what we call a neuroendocrine protocol. So which is basically we try to take a picture with an arterial image where we give the dye and take a quick picture, and then a venous image where the dye is washed out and then take a picture. And you can clearly see how well we can see these tumors and the actual extent. So imagine some of the smaller tumors that you may never get to see if you don't get a good protocol of the CT. Now, MRI for those reasons sometimes is preferred in some places. MRI is harder to get, like more cumbersome for the patient. So again, between CT and MRI, as long as you get a good CT in a good place, good protocol, good MRI, and we can see what we need to see, that's adequate. So, and it's hard to compare if someone gets a CT like this and then comes up 3 months later to our clinic and says, is my tumor growing? I mean, it could be just because the CT was like a different protocol. I really can't make a judgment on that part. So symptoms can be very different. As we know, some patients may come with a lot of tumor in the liver, losing weight. Some of the patients that Dr. White described, these are all scans from patients in our clinic. So came in with a lot of weight loss, 20, 30 pounds, pain, discomfort, was a pancreatic neuroendocrine tumor. A subsequent scan after treatment with capecitabine temozolomide might beautifully reduce this tumor. This patient came in with actually what was just localized tumor. So when people say ascites, this is what it looks like, this gray color within, this is your belly cavity, this is your spine. These are all loops of bowel, but you can see this kind of dark gray in the background, that's the fluid in the belly, or what we call as ascites. This patient actually did not have much tumor in his liver or other areas, but it was the wrong location. This is the lymph node compressing on the blood vessel, which was impeding the flow and absorption, leading to this ascites, and he was very symptomatic from that. Now another patient with this is actually a large pancreatic neuroendocrine tumor. So you're looking at your liver here, that's normal. Spine, the patient is lying down on the table, and that's your stomach in the front. But you can see this pancreatic mass has pretty much pushed down the kidney and the adrenal glands, and a lot of back pain. So even though patient did not have what we call a metastatic, maybe like spread, these can all be symptomatic. These patients need treatment, even though they are not advanced or spread or growing. When you see them, you have to treat them to make them feel better from the tumor bulk perspective. Some patients may come in occasionally with bleeding in the gut because the tumor is in the pancreas head, eroding into the gut and bleeding. Now, patients sometimes may come in with a scan like this, which is a gallium PET peppered with bone, and be asymptomatic. So that can also happen. So treatment decisions have to consider symptoms from the tumor bulk and if they need it. The other type of symptoms, as was extensively described by Dr. Dillon, is the carcinoid flush or the diarrhea. This is actually also one of our patients who had a glucogonoma rash, actually presented with poorly controlled diabetes and a rash. So he went to a dermatologist and he went to an endocrinologist. And then he got a scan for actually a kidney stone, nothing to do with any of that. And that actually showed a large pancreatic mass. And somebody put three things together, ended up being a glucogonoma, which is like a type of secretory pancreas neuroendocrine tumor. And these legs, after surgery, pretty much the rash disappeared. So carcinoid heart disease, this is actually showing like a normal valve. This is like a valve with three cusps. Like these are three parts of the valve that should close completely and open to let blood flow one way. Now, when there is serotonin from the tumor disrupting this, destroying these valve leaflets, this can happen. So these are all symptoms presentation. So I think the patient factors I kind of skipped through. It's important to consider all of this before making treatment decisions. I would also mention access to care, financial burden, and caregiver support, and patient values and preferences beyond the age comorbid conditions. I can write any treatment, the patient has to be able to get there. They have to have a caregiver if I'm giving chemotherapy and they're going to have side effects. So kudos to all the caregivers in the audience today on top of the patients, because this is an important part of treatment planning and treatment decisions. So the other thing, back to the toolbox, I'm going to probably hurry up a little bit. So the big drugs we know are octreotide analogs. Often even a medical oncologist like these drugs and start out as long as there are receptors on either octreotide or lanreotide. And this is across the board, any origin tumor, any site of tumor. Now, they have not just shown control of the hormones, but also control of the tumor growth to some extent, but they never shrink the tumors. But you can be on cruise control mode as long as you're asymptomatic for a long time. And even if the tumor grows, sometimes we say, let's hold back. We don't have to jump to some other treatment right away, because this is a disease that's chronic. So we have to make sure when we intervene, there has to be a reason, and there has to be actually a discussion about the side effects and other things. So the other drug that often is the medical oncologist that you may hear about is the Afinitor or everolimus. So this is the seminal study that looked at non-functional neuroendocrine tumors, either of pretty much small bowel, lung, or any origin, low grade, grade 1, grade 2. And this showed, compared to placebo in red here, people who got the Afinitor, the tumor slowed. The median OS, which means median progression free, so about for 11 months. So half the patients had the tumor grow before 11 months, and half the patients got benefit even beyond 11 months. So that doesn't mean it's going to work for 11 months. So that is what a median means in these kind of curves. But if you look at the side effects, I think that's probably what dissuades a lot of people from coming to see an oncologist. The diarrhea, the mouth sores in at least 1/3 of the patient, and over 2/3 the mouth sores to some degree. Grade 1, 2, and 3 refers to the severity assessed by clinician, not by a patient. So you could have 2 mouth sores and still not complain, but it's still 2 mouth sores that affects you. For me, I'm going to grade this grade 3 when you're losing 10% weight, but that's not fair because you have mouth sores even at grade 1. So I think that's important to consider as a patient too. Pancreatic neuroendocrine tumors, I just put a list of drugs that we use and also what we call a response rate. Response rate here refers to radiographic, meaning what actually happens in the scan in terms of shrinkage. So as you can see, everolimus, which is a drug that is more of a cruise control drug, out of 100 people I give this to, only 3 may actually have shrinkage, but a good chunk of those patients may have stability for a long time. Sunitinib, another drug that we use specifically only in pancreatic, may shrink it to a slightly higher degree. So if a patient comes in with a large tumor, painful, or the liver full of tumor, probably going with one of those options is not a great idea because you want the tumors to actually shrink. So I would probably use something like the capecitabine or temozolomide, which is especially if it's pancreatic origin, because they can shrink in a larger number of patients and get them out of the symptom burden quickly. I did not put PRRT, but PRRT also has a fairly high chance of shrinking now that we know from NETTER-2 data, which is a clinical trial that was done recently. So this is sunitinib, which is again a drug that's exclusively at this point FDA approved in pancreatic neuroendocrine tumor. And there you can again see the side effects again can sometimes be a discussion point, mainly diarrhea, and this, I guess, asthenia is basically the blah feeling, like I guess there's no other better way to describe it, and then the hands and feet that can have rashes from this drug. So again, it's definitely not easy to take some of these drugs. They also have an impact, but they are part of the toolbox, and there's likely the chance that you will need to use them at some point. So chemotherapy started out with the retrospective study of just 30 patients when they gave this drug combination called CAPE-10, and almost 70% in that small series had objective shrinkage of tumor in pancreatic origin. So that led to a large study where they looked at two combinations, temozolomide versus capecitabine temozolomide. So it's important to know that even if you give temozolomide, which is like one chemotherapy drug, you could also have shrinkage. The reason is some patients have kidney dysfunction and not be able to do this combination, because this particular drug called capecitabine, only if you have good kidney numbers you can get the drug. So I think it's a good study to reference to say, yes, great if you do the capecitabine temozolomide combination, but if your kidneys are not permitting and you have a pancreatic neuroendocrine tumor and you need shrinkage, temozolomide alone, which is safe even if you don't have the best kidneys, can be an option and it can also shrink tumor. So if you look at this curve, or basically looking at the difference between the two drugs, temozolomide and capecitabine, the combination did better. There's somewhat of a separation, that's a better curve. But if you look at the response rate, so this is more new data, so if you use these drug combinations in chemotherapy drugs in pancreatic, 30% shrinkage can happen. So with that, there are many ongoing studies. The most recently concluded study called CABINET, which is looking at a drug called cabozantinib, was compared to placebo. And importantly, this particular drug, which comes in the same category of drug as sunitinib, included not just pancreatic neuroendocrine. This included patients with pancreatic and extrapancreatic neuroendocrine tumors. And it saw activity. This is actually the pancreatic neuroendocrine tumor, where there was definitely difference between the survival. And then also the extrapancreatic, meaning those with lung or small bowel tumors, also the drug had activity compared to placebo, and they stopped the trial because it was positive. The biggest challenge is how do we use all these treatments in addition to all the other treatments like surgery, embolization, and also PRRT, and that's probably one question that's not well answered, because it's hard to conduct a study that can answer a question of what comes first and what comes next. And that's simply because the patient population is so heterogeneous, meaning you cannot kind of find a theme and put all those patients in one theme in one study. There's so many nuances to this, but there's definitely ongoing efforts about how to go about a sequence. So some of the studies that I would want to tell patients about or to consider enrolling is actually a study that is looking at PRRT versus capecitabine temozolomide. Another study that's looking at a type of PRRT with chemotherapy as another arm. Another study that's looking at comparing to everolimus. So these are some studies that are going on trying to answer the question of, mainly with PRRT as a comparison of what would be a good sequence, if possible, to address this question. So I'm probably over time. I'm going to talk about only one thing about the heterogeneity, because I probably have the slides that explain this concept of heterogeneity that people have been talking about. So we've been talking about grade 3, and grade 3 tends to be more heterogeneous. But what does it mean? So this is a patient with a scan of tumor in his liver. This is a gallium PET that shows these tumors, but if you see, there's only sugar PET or FDG PET, as we refer to, in these areas. So among all the tumors, this particular tumor has some bad behavior going on, and though has receptors, is kind of acting a little differently. So this is what we refer to as a heterogeneous group, or patients who have some bad elements hiding between the good elements. It's important to pick this up or to recognize this when this happens, because again, treatment plans are changed, treatment options could change. The receptors may be lost in some patients, like one of the patients I showed, and these are the situations. As a medical oncologist, I'm all about tissue again as possible, or a clinical behavior, and try to biopsy and get a new assessment on the tumor testing. Dr. Malicia mentioned about next generation sequencing, and certainly these patients, we do that. I would also be cautiously optimistic. The odds of actually finding what we call an actionable mutation, where we actually can have a drug that greatly matches, is unfortunately not very high. So this is an area of very high unmet need, and this would be my treatment algorithm for a G3 disease, looking at receptor status. If there's receptor status, still have PRRT in the pocket of things or octreotide therapy in the pocket of things. But if you don't have octreotide receptors, then you probably don't have these options. And then if you have a very poorly differentiated, high proliferative tumor, then you're probably looking mostly at different types of chemotherapeutic drugs, and in some cases, immunotherapy. So with that, I will probably conclude. Thank you.